Thank you, Niranjan, and thank you also for thinking to include in an ophthalmic conference someone who is not an ophthalmologist and not from a clinical perspective, because of all children, this group, children with whatever we want to call them, CVI, are children who can only benefit if we work better as a team. And much of what I hope this talk will do is, for me, always to listen to ophthalmologists is an education, because I understand the perspective with which you approach the child, what it means when you use very similar words, but we mean very different things from an educational perspective. And this helps me when I actually do my practice. I understand your approach, your priorities, and I hope by the end of this you have a sense of ours as well. So the first and most important thing for me is always that the primary goal of rehabilitation, regardless of whether I'm a physiotherapist, an occupational therapist, or a vision therapist, is always the promotion of activities, the child's participation in activities. It's never the promotion of vision or the promotion of the motor system, unless at its core is that it's going to benefit or increase that child's access or ability to participate. And we look at this, this is very, very key, particularly with children who have complex impairment, because sometimes we do need to make that call. I will speak very specifically to the situation we have here in India, where, as Niranjan said, we have very little time, we have very many children, and we have very few professionals. So within this reality, when I give advice to families, I change my advice based on what I think will result in the best, most optimal outcome for the child, which may include forget training vision. And for this, I know I get a lot of flack, but the result is that we have children who grow into adults who are competent and participating, and this is the goal of rehabilitation. When we do assessment, or when we think about making recommendations, we always think about these 4 areas. Communication, that's what you're seeing here, these little kids talking together. We look at movement, we look at learning, and we look at reading. This is for children specifically, and this kind of maps onto what ICF asks us to look at. In general, we do not look at stimulation, because stimulation by itself has very little value to children. We are active, the stimulus is active, and children are passive. If you really want development to happen outside of yourself, you need to focus on enabling children to develop a curiosity, a high motivation to use the system that you are training. And that is promoting development. It's not using stimulation. So the key of all the intervention that we design is that we want kids to want to see, to want to use their vision, to be interested, to be curious, and to start to trust their visual system as an important source of information. And we do this then, the child you see here is a child with cerebral palsy, a child who has massive areas of damage in his brain, and also a child who has optic atrophy. So there is an ocular limit to what we can see this child is going to achieve. But when I look at all the other areas and how profoundly they are limited, it's well worth it for me to push him to be excited about using his pretty bad vision. We work also on the principle that you really enjoy things where you've worked, where it was a little difficult and you tried and then you got it. And that excitement, that pleasure of getting it is something that you see even in infancy. You see it in a baby just a couple of months old. And this is what promotes change. If you understand how the brain develops and you understand what enables the brain to wire successfully, this is something that's very key. A child should not be given things only that they see easily or can do easily, but things that present just that little edge of challenge. Ensure that there is success, and also always give them these contexts: communication, learning, movement, etc. We know and have known for a long time, Hebb taught us this, 1949, he said, cells that fire together wire together. And this forms the basis then of all the intervention that we design. We try to ensure that learning is always active, no passive stimulation. We make sure that they have a lot of fun. We make sure that they work hard, and we make sure that they succeed. All these elements are very key. If you do that, you will see visual improvement. We keep pretty detailed track, but it's actually quite easy, of each of our sessions. And this gets converted into a simple visual chart. It's a very andaz chart. I don't obsess about every half point and quarter point, but at a glance I can look to see what's going on. Why is something changing, something else not changing? What am I seeing, and what do I need to fix? What I do want to talk about are the most common questions that I get from clinical practitioners. And in terms of how do we give advice, or what do we say to parents, or what can I expect? Some questions are, how bad is bad enough that I tell the parents don't even try? How far can I expect a child who has very minimal visual response to improve? How much time is enough for me to be able to give them good advice, something Niranjan has spoken a bit about? How late is too late? What if I get a 12-year-old? And finally, I don't know if I'll have time to get to this. Our definition of good vision lies in visual acuity. This is what we use in school screenings. This is what we use in infant screenings, Balwadi screenings. The assumption is good acuity means good visual functions. And the reality is this is not true. Poor grating acuity equally is seen as an indicator of profound difficulties. And in reality, we know this is also not true. So let's come back to the questions. How bad is too bad? Should I bother with intervention? And this I'm going to tell you just by giving you a couple of case studies. We have, of course, have had disasters, and we've had children who don't improve. But I want to talk about the ones who do. This is a child who came to us at 5 months, microcephaly, extensive damage, cerebral palsy, CVI, half a dozen diagnoses. Inconsistent response, very, very inconsistent response to light. Eyes often open, very blank stare, couldn't get much response to pretty much anything. But we continued with our basic principles of intervention. We always give children between 3 and 6 months if they come to us regularly. 3 to 6 months is a minimum time. If I do home guidance, 3 to 6 months is a minimum time that I tell parents they just do it like religion. You have to do it, get up every day, you have to do this. After 3 months, we make a decision how we proceed. We select objects that has a visual quality that works for every child, and contrary to popular literature, this is not things that are yellow or blue or some random color. They do differ significantly from child to child. And we select activities that repeat often. And with a child who has very profound no response, low response, very, very inconsistent response, we use touch. We give them something so that they recognize it through touch, and then we wait. And when you wait, and sure enough, you will get a look, but you really, really have to wait. Touch confirms, and this is what we've understood. The vision and touch are the senses that are closest together. They complement each other. They get you the same kind of information. Touch is harder to process than vision is. But touch will give you that idea that this thing that I see has substance, how big is it, how wide is it, etc., etc. And so it fills in the details that a child is not able to immediately at one shot get just by using his eyes. This child came to us on a regular basis, and one of the things that we do is we identify points in the day where we do a repeated high chance for success activities. I encourage people to use things like hands because they actually are brilliant, especially our nice brown hands make fabulous visual stimulation. We have slightly oily, nice, white reflective surfaces here and a darker dull surface at the back. You can use movement, you can use the warmth of your hand, you can use sound, you can really play with how you use your hand. We stand outside the classroom as the children come in and have our hands catch light. And as they catch light, children come in, they're supposed to look and touch our hands, and then we sing a hello song and a bye-bye song. And this activity we make as fun, as long or short as it's required. Every child does this. And you'd be surprised that every child, including this boy, looks, reaches, and places his hand accurately. How far, how good does it get? Again, yes, I've had children who started with no consistent response to light and ended with doing print. So I've had children really go across. But let me pick an intermediate boy. He was one who came to us pretty late. He was 29 months when he came. He had no response to light, except that his eyes were closed, which is a response to light. He opens his eyes at night, and he had this weird difficulty in using his body. It's as if the parts of his body were not really well connected. He would sit floppy, just sit very stable and be unable to even do a guided lift of his hand. It took him a very, very long time, and his mother's primary concern was he doesn't smile. We had a hard time figuring out what attracts his vision, what distracts his vision, and what maintains his vision. And as you'll see in these pictures, here we are using sound, and it immediately grasps the first child's attention, but the second one loses visual attention as soon as the tap water drops. The same way, the ball grabs and maintains visual attention for one child and is overwhelming for the next. So these are visual principles, but you have to watch and pick, and sometimes it's really hard. With him, it was textured material, and this is something that we create very simple toys that we often give to families. They intersect, the tactile and the visual boundaries intersect, and we find that this notion is something that really works. With this child, we didn't know whether he would ever develop useful vision, but we wanted at the same time to build this tactile system so that he always had some useful way of participating in life. So by 6 months, he could touch familiar objects. He could look briefly to his mother's face, and for the first time, we saw facial expressions. This was after using this. At 5 years, this is a boy who could look at a photograph of known people and known objects and select the one that we ask him to. So you can come pretty far. How much time is enough to make a good assessment plan or an intervention plan and pass it on to families? This is a child who came to us again very late, 42 months, with a deep attachment with her dad. It was lovely to see. Significant developmental delays across all areas. We think she had auditory processing, visual processing, huge levels of difficulty. And the only vision was that she would turn toward a large light source and stop when there was any shadow in front of it. We used this. We had, of course, all these challenges: late, limited capacity, parents from a village, and just that one chance. So we picked one single suggestion that we knew was likely to succeed, and we co-trained her auditory and touch. The intervention that we suggested was very simple. We said, we want this girl to want to see and to know that she can see, because somehow her brain doesn't get it. It was a very simplified explanation. And we taught the dad to play a simple game of dodging in and out of the light very close to his child. And she would look at him and he'd say, "Oh, you saw me," and reach across and get her. And soon it became, "Come and get me," and so on and so on. And we gave him these materials because these also very simply move, they have good boundaries, and use this as a way to get her started. We did all this. We always give parents materials because telling them to go and get it is too hard. We sent them off, and for 2 years they disappeared, came back at age 6 with the child admitted in the local school saying that if I give her a book, she still only responded when asked specifically, but they said if I give her a book and tell her, find this, show me this, alphabets and pictures, the child can do. So good goal setting, excellent family, religiously followed through, and pretty stunning results. How late is too late? This is a boy who came to us at age 9. He could see nothing. He would get lost. If I gave him something on a page, he would get lost. He'd say there's nothing on it. He couldn't visually identify people. But by the end of 6 months training, we saw this big jump. And today, as a young man, that's Leah testing him, he can read with difficulty, but he can identify symbols on a page. So we know that change is possible pretty much across ages. We haven't worked with adults, we've only worked with children, but we've pretty much always been able to move kids up a couple of steps. So how bad? There is no such thing. We say try with every single person. How far can user vision improve? We don't really know. We learn with each child. We certainly have children who hit limits and stay there, but because we use tactile as well as vision, auditory tactile vision, there's always some strategy that's going to work for a kid. One session you can be effective if you know your job well. And how late is too late? We haven't yet found that boundary. So I'm going to stop here because I think I've run out of time and pass on to Shweta.